start that now. And so we are recording and live. So yeah, thank you very, very much, everyone. Welcome to our Vanui event for the month of September. Just a couple of small things before we introduce our speakers for tonight. Just wanted to thank the founding sponsors. Just first of all, so thanking OXD as well as Habanero. So just a couple of housekeeping items there. As well, thanking in advance, we're going to be donating all of the fees tonight for to the Greater Vancouver Food Bank, just to continue to help causes in need, especially during these continuing trying times. All right, so tonight's talk is the agony and ecstasy of developing an effective digital strategy. So just wanted to introduce Rob Attwell. Rob Attwell is the Chief Operating Officer and founder of Careteam. So he's an entrepreneur who has extensive experience helping large healthcare organizations with significant innovation and transformation initiatives. He's also responsible for the strategic initiatives and partnerships, including Careteam's work with the Canadian Digital Technology Supercluster. He's an advisor to and past chair of the Neil Squire Society, a national not-for-profit providing services to Canadians with disabilities. He's got an MBA from the Richard Ivey School of Business, where he was recognized as an Ivey Scholar and is a recipient of the Ivey Alumni Award. His company is Careteam. It's a healthcare grade team collaboration platform. Brings together healthcare professionals, the patient, and their personal support team with an integrated health care plan, instant communications, and population analytics to enable transitions, complex chronic care, and innovation in a fragmented healthcare environment. They create an ecosystem of data integration and security, and it also supports healthcare apps as well as AI. And then he will be joining Karen Zuidinga in this fireside chat. So Karen is an expert at translating business strategy into digital action. For more than 2 decades, she's been helping organizations create, redesign, and innovate new digital products and services. And she has a reputation for asking great questions, filtering the silence from the noise, and rapidly identifying impactful digital opportunities. She's helped several prominent organizations evolve their offering, including AT&T, Adobe, Amazon, Samsung, and the government of BC. So without further ado, I'm going to stop sharing and gonna pin Rob and pin Karen here.
And thank you so much, Dave. That was really great. It's so smooth.
Perfect.
Yeah, so welcome everybody. The agony and the ecstasy of developing an effective digital strategy. It's a lot of words. And for any of you who have tried to implement your digital strategy, chances are you've felt that agony and that ecstasy. So what we're going to do is we're going to just have a conversation with Rob tonight. If you could stay on mute while we're talking, if you've got questions that come up, please throw them into the chat. We're more than happy to try to answer them as we go. Dave or Curtis may jump in, and if they see a great question, stop me or stop Rob and dig into something. You know, we've got Rob here. He's completely agreed to being on the barbecue and being grilled tonight. So yeah, just fire away. If you've got something you want to dig into, I'm more than happy to dive down that rabbit hole with you. So, Rob, hello, and thank you.
Thanks for having me.
Yeah, you bet. I'm so excited to do this, actually. It's been quite a long time. I was there at the birth of Careteam, and now a few years later, it's evolved and changed and done a lot of things. So for those who don't know, can you tell us about Careteam? Maybe share a few screens and sort of, you know, the words healthcare grade team collaboration platform is a lot of words, but I don't know what that means for me as a user.
Okay, sounds good. Okay, good. Well, so Careteam is kind of a big idea. You know, what we're trying to do with Careteam is to create a or improve the patient experience in healthcare. And so the problem that we have is that, you know, healthcare is very siloed and very fragmented. And so what we've done is to create something that's unique and something that we think is needed for the ecosystem, which is to sort of help the patient control their own information and have info and understand what their journey is in order to know what they need to do next in order to get better or to manage their health care, or I think a word is not to have perfect health, but to optimize their health. So what we had to do though is to build an enterprise system, which is very difficult because you have to be, you know, you have to be able to pass muster and privacy impact assessments and, you know, and all kinds of stress testing and so on by healthcare systems. But I think that to give you kind of the basic idea of Careteam is that we're what we call a P. We're based on a plan. So we've created a healthcare system that's based on planning for the future and the journey, as opposed to an R, which is a record. So you hear things like ERs and EMRs and so on. And we're like, hey, who cares? Like, you know, the province can give you or your healthcare provider can provide you with your records, but nobody actually cares because you can't do anything with it. But, you know, people care about what they need to do next, what their appointments are, who can help, what resources are available, and so on, and, you know, what meds their mom needs to be on or their child, and so on. So yeah, so that's kind of the, you know, the sort of the big idea in terms, and so what, and just to give you a couple of the sort of nuggets about Careteam, what we're trying to do is to be an overlay to existing health IT systems, which are really focused on billing and administration, and they're starting to evolve into more kind of clinical care oriented systems. So healthcare in the US is very money and administration oriented. And so everybody in the world gets these systems that are built to the US market that are not very good. So we're creating something that sits on top of it that can actually focus and be patient centric rather than money and administration and centric.
Cool. Can you share your screen and just give us a couple of examples? And while you're showing us, can you kind of highlight the difference between what you're doing and what I was starting to hear a little bit at the beginning, which was electronic health records? I'm like, well, how is this really different? And I like what you said, that you're P, not R. So can you just give us a sense of how what you're doing is different from electronic health records?
Sure, okay. So I will share my screen and okay, is that showing up?
Yep.
Okay, so this is a login screen, obviously. So I'm going to show you the patient side, and which is very similar to the practitioner side. So this is a patient. So this is all, as you can imagine, made up data because we can't show you private health data or information for obvious reasons. And so what this does is to show you just a number of care plans for patients. So this patient has gone to several venues. And so what's different about this from other healthcare applications is that everything in healthcare tends to be within the organization and within the silo. And so you can see we've got something from Memorial Hospital, and then we've got something from Lakeside Medical Clinic. These are, of course, fictional places. And so patients being able to pull these into their, and have them in one location, and that's unique. You don't have that in healthcare. So if we look at the life after heart attack plan, please don't have a heart attack, any of you. So it sort of gives some information about what they have. There's a little bit of information about their, about Jean's, in terms of her medical number and those kinds of things. So there are a couple of tasks that she needs to do, and then there's some tasks that have been completed, and then there's other information that they can have. Now, she can add tasks and she can add appointments and so on for herself, but those can also be populated automatically from health systems and booking systems and so on. And so in healthcare, as much as possible, you need to be able to automate the introduction of events and appointments and so on, and have them developed through care pathways and automated sort of or programmatic sort of actions and so on. So a few things here, there's some resources that are available to her, and then there's information about her team. And so the way we think about what Careteam is, it has 4 Ps. There's the people involved in it. So you can see she has a number of contacts, her spouse, members of the care team who are there to help and what their roles are, and then their extended people. And so all of these people have different levels of access to the information that they have. So the neighbor can't see the healthcare information, and the physicians can't see the chat between the family members. So, and everything in between. So this is unusual because in healthcare, you don't have access to a view of who's involved in the circle of patients. And so what's also unique about this is that you don't have access to care plans across conditions. So usually a person with diabetes also has, or may also have heart failure or hypertension and so on. And so, but these conditions and the physicians and the teams that are managing those, except for the primary care physician, tend to be siloed. And so what this does is that we provide Jean with the ability to share her care plans and information with other physicians or nurses, private nurses, or family members in order to, and at different levels of granularity, in order to be able to, in order to let them see what's happening. So this could include documents and other information about their, about her sort of healthcare journey. So then there's so there's the people, there's the plan, and then so this is a little bit about the plan, their documents, their list of tasks, and so on. And then there's also information about her progress. And so this is the health status. So this might have information about, you know, daily check-ins, if it's pain levels or weight for heart failure and so on. And so, you know, there's a lot of data that we can bring into this and then have, and she can share this with people that would normally not be able to see it. So I'll log out and show you the physicians or the clinician side.
It's a lot of integration work, what I'm seeing here.
Absolutely. So a lot of this has to do with tying into other systems and so on. So this is the physician side. And so the physician logs into one place and then can access the system for different, you know, for the different locations where they are. But then, you know, there's different things that they have. So they're going to have lots more people. They need search functionality. They need to, you know, access information or access the records differently. And they will tend to only see the medical information about the person. And so, so here's Jean down here, and you can see these are the 2 care plans for this role that the clinician has. And then they can deploy new care plans and templates and so on. And if there are messages, if they want to switch on messages or be able to enable this person to message them, they can do so or not. And you can have group chat, you can have, you know, you can create channels of chat and so on. But this tends to be a bit too much for physicians because they are way too busy. So it will tend to be an office assistant or a nurse that's doing discharge and planning that will use it. So there, I think it sort of gives you a feel, oops, something went wrong.
It's a remarkable achievement to have gotten to where you've gotten. And I'm thinking about things like digital banking or fintech and how far they've gotten. And I'm thinking that seems complicated, but this seems like an order of magnitude more difficult. Can you talk about that for a second? That just the complexity that of the space that you're playing in and how that might affect your strategy or design decisions as you're moving along?
Yeah, it's interesting. I mean, the healthcare and fintech are interesting comparisons because if you think about where we are with banking, and you know where we've come. So you know, when I was a kid, I used to take my passbook in and have my balance updated, and I'd have $15.20 or something like that.
Right.
Maybe I never had that much money in the bank, but you know, at some point, the bank allowed me to go and do automatic withdrawals or deposits at their location in the machine. And at some point later, those became networked, and I could then go to any of those branches and access them. Then, of course, I could then go to other banks. You know, when the interoperability between banks, and I could do it overseas. and I could do more and more functions. And then, now the bank has kind of said, hey, you guys should just do everything. Don't come in unless you absolutely have to, or if you need to get your safe deposit box, and you can do everything online, including sending wire transfers and requesting for money and so on, because what happens is that drives their business model. So we're kind of somewhere near the ATM level, or maybe inside the network with healthcare. There's very little interconnection, and that has to do
even within one silo. I was dealing with a situation with my brother today, actually, where one part of the hospital that he went to has no idea what another part of the hospital is doing with him. Like, it's no communication whatsoever. So
business banking and personal banking don't work. Where I can see one account and another account. Right?
Yeah, exactly.
So, I mean, a lot of that has to do, so there is a lot of complexity. So healthcare is difficult, and healthcare is complex because you have a lot of actors and a lot of people. So payers, there are privacy requirements. So the environment tends to be incredibly conservative in terms of allowing access to data. Like, why is this SME? What's this little care team company? Why do they want to use this health medical information? There's a lot of risk. Is this worth it?
Yeah.
So, and then the other thing is the technology is really built for silos, and and the environment. And just because there's so much complexity, there's so many interactions, there's so many people that touch a patient and their journey. It tends to be, very simple things are done with technology as opposed to, sort of big ideas and integrations, both because of the conservatism and the number of people involved. And then the other thing is there's been underinvestment compared to other sectors in terms of healthcare, innovation, and so on. So it's a very challenging environment to be. This is one of the big blind spots I had going into the space. I didn't realize how difficult it would be to deal with hospitals and so on. Just one other thing I'd say is just that the medical world is you're dealing with people who are so busy. They just don't have time to do another thing. And most physicians didn't think they would spend 40% of their time entering information on a computer. They thought they'd be speaking to patients and, having the stethoscope out rather than the iPad. So anyway, it makes it difficult.
So there you were going along with all this complexity, and then COVID happened. And, so I suspect that added another layer, both in terms of complexity, because now it's even harder to reach people, talk to people, do the things you're going to do. But also I think it probably all opened up opportunity, because now we're thinking, well, how can we do more, better online?
Yeah. So, I mean, COVID has been just a massive event for digital health. I would say it's accelerated digital health by 10 years. So a lot of things, where policy makers and decision makers and budget holders weren't willing to do things, weren't allowed. So, one of the things that you have to understand about healthcare is everything happens based on whatever drives people's work life. And so what drives people's work life is how they get paid. And so physicians and hospitals, not just physicians, but hospitals do things that they're paid to do. And so they, and things that drive their economic model. If they care about ratings because ratings are published, then they will care more about patient engagement and so on. So, but what COVID has done is to free up a lot of money just because they can't see people in person. They couldn't see people in person. So, what happened with COVID is that obviously, elective surgery and early detection kinds of programs and even mainline treatments were really sort of halted for a lot of people. And we're obviously going to have a big, there's going to be a big overhang of undetected disease or untreated disease and so on that will happen. And we're starting to see people invest in solutions because they recognize that coming. But COVID has made decision makers less conservative about digital health because they now have to find ways to solve the problems. It's now driving their economic model. They want to see patients. If they want to deal with conditions and avoid making things more expensive later, they have to invest. But it's still extremely difficult, but you still have that complexity, but you're starting to see we're now starting to network things a little bit, or get a little bit
Yeah.
more involved, but very
A little
challenging.
more openness. Yeah. So I'm thinking about, the impact of COVID and this new openness to some of these ideas that's starting to bubble up on the healthcare side. Is that stimulating any new ideas for you about the direction of the app, the kind of things that you can do in it, the way that you might be able to network systems?
Well, it definitely has. I mean, there have been, a couple things. We've seen that, what we've seen in COVID is that very simple solutions can have a very big impact. And so one of our partner companies is called Thrive Health, which we work with and admire, and they look a lot like Careteam, but they work at a different part of the value chain. But what we found is that very simple solutions that are easy for everybody to understand have been very successful. So they did the COVID self-assessment tool, and within a couple of weeks they had 8 or 10 million people download this thing. And I spoke to their CEO, who's a friend and a partner, and he was like kind of embarrassed to talk to me. He's like, well, it's kind of sorry, we would have done more if we had more time and so on. And I was like, but what it did was it demonstrated that they could keep 60% of the unnecessary sort of admissions to the emergency department away from things. They could reduce the impact on nurse lines. And so for us, that was, we wish we had done what they had done, and had the foresight to do it, or that our technology did more of what their technology does. But they were well positioned to do it. But what it did was it demonstrated that that digital health can provide tangible value and really drive the economic model of the hospitals and of the healthcare system. And so BC did it first, but then it spread. So they were absolutely overwhelmed. I think nobody took a day off for about 5 weeks at their companies, just because they were so overwhelmed by demand.
Wow.
So that's great. That's a good story.
Yeah, that's a win. So I described in my recent LinkedIn post, I described Careteam as on the cusp of becoming the connective tissue for the healthcare system, because that's how I'm starting to visualize Careteam. Could you tell me if you guys are successful, if you win, if Careteam takes off, and we all touch it when someone in our family gets sick, what does the world look like for me as a user of Careteam? Like what is the change we'll see in the world when Careteam is
That's good.
successful?
Good. If you believe, yeah, I'll send a subscription agreement to you later.
Thank you. Thank you. I appreciate that.
So, the big vision that we have is we want to be kind of a third place. So if you think about, you have Facebook or Instagram for your social life, and you have LinkedIn for your professional life, but that sort of private healthcare identity and so on is something that you don't have, that sort of private space for your family and your trusted circle. And so the big idea is to provide that, or to enable that. And so at scale, large healthcare providers like Kaiser Permanente or the NHS would adopt.
Wow.
And so the big idea that we have is to be sort of implemented from the top down by, it could be national governments or entire, healthcare systems. These are 60 or $100 billion companies. That's a big journey, and it's a big idea. So we're starting to see the genesis of that with there's strategies in Ontario where they're trying to transform healthcare with something called the Ontario Health Teams, which is kind of like the British Columbia health authorities. And so they just don't have an application. So they found Careteam. So we have about 5 these Ontario Health Teams that are starting to use us to do that. But if they all started to use it, if you were in Barrie or Surrey or Vancouver or Seattle, all of those care plans, and we were adopted on a mass scale, all of those care plans would be in a single place. So you could see your entire health journey or share all the information with others. Now, obviously that's kind of Google level of success. But we're kind of we're a big idea, and we're kind of a crazy idea. It's a bit quixotic, I'd have to say. But a lot, the advantage of that is it excites a lot of people who say, yes, this is the way it should work. Is it doable is another thing. So so we have to sort of figure out a way to, get to that sort of level. And so the Ontario Health Teams are a very good opportunity, because they potentially could show and demonstrate spread within an entire ecosystem. That could, so if we have those kinds of use cases which demonstrate adoption and success across conditions, across an ecosystem, then, it sort of will lead to funding rounds and so on. So we've spent about $4.5 million on this so far, which is a drop in the bucket of what we'll need to spend in order to be successful. This is more like $100 million, thing to get to like a real level and then go from there. So it's anyway, so as I say to my family members, if we survive, we'll be amazing. So
well, I think I as you know, I've been a supporter of this idea from the get-go. I really love the idea. I can hardly wait till you are there because, as I say, I am personally experiencing a need for Careteam today. I really, really wish it was there and working because the healthcare systems are, especially with complex situations, are very difficult to navigate.
yeah.
The world, the medical world tends to look at you as this organ or this problem and not so much this whole body with all of your problems, right?
Yeah, and the other thing is that, most healthcare interactions happen outside the formal system of healthcare. So,
Yeah.
We do a few transactions that make us get better, get sicker, but there are a few of those transactions which hopefully make us better within the four walls of the hospital. But the future of healthcare is, we say that the future of healthcare is off the mainframe. That's and that's from an Intel fellow named Eric Dishman. He did a TED talk in like 2006, which had that title. But consumers don't want to be treated inside the formal system. We don't have the capacity to do that, but we have the technology and changing attitudes that will lead to a different way that healthcare is delivered. But the other problem that we have is that healthcare is delivered very medically, and so people, as you say, people think of you as an organ or a disease state or a condition that needs to be solved. And once that's solved, then you are discharged from somebody's care and there's nobody to pick it up. And so what you see, places like the NHS in the UK are changing their funding models. So they're combining health and social care. So you probably heard the term social determinants of health. Well, why didn't you get to your chemo or why didn't you take your drugs? Well, I didn't take my drugs because I didn't have the money to do it, or I was getting sick and nobody followed up or cared. These drugs, I don't want to take these drugs because I feel nauseous when I do it. Or I couldn't get a ride to get to my chemo, or I had childcare problems. And so we're trying to create capacity around a patient by letting their family members get involved and be part of that journey, which is not typical. And so we have to get the healthcare system to buy into this, because the things that drive people back to the emergency department or make them get sicker and stay in hospital longer happen often outside the hospital. And so we have the challenge for us is to make it work and actually have an impact on people's health, but also demonstrate that affects their business model or their economic engine.
Yeah. So I'm kind of curious about the things that you're working in a really complex system. You've probably over this time tried things that didn't work and then backed up and maybe tried something else. Can you just give us a little bit of insight into some of the things that you might have tried that, don't do that. And maybe some of the things that work that you're like, whoa, hey, that worked.
Yeah. Okay. From a UX perspective, I think the biggest thing that we've done that I think was a flaw. Our UX is deeply flawed, and so we're in the process. It's a constant journey, and so it's the old thing. If you're not embarrassed about your design or UX, you waited too long. But we've had an embarrassing UX for too long already. So we have problems in terms of the scalability of the UX. The other thing is that one of the biggest flaws that we have in this is that the UX for the end user is too clinical, and the UX for the clinical side is too consumer oriented. And so we're starting to separate those things and make them different, because what you
Mm-hmm.
need, what the healthcare side needs, is everything to come in automatically, and for them to experience care. That we need to be invisible to them. They need to be able to experience Careteam in their EMR or in their own systems, and be able to interact with our system without touching. They don't want to log into Careteam, even if we have SSO, or even if it's dead. They just don't care. They don't want it. They're too busy. You know, give it to me in the way I do all my other things. And so for the consumers, it needs to be more dynamic. And so, you know, we brought 2 new people on this year to become, orders of magnitude more data oriented. And so we're introducing a concept. I guess our sort of, in terms of thinking about what, we have a relatively flat application right now in terms of the user experience, in terms of, meaning it's just not that exciting. It's not that it needs to be exciting, but it needs to be engaging. Like we're not trying to make people come back every day and use it, because I don't want, if my healthcare is not a problem, I don't want to use it.
Right.
So, but you think about this, is when I need to use it, we want Careteam to be like the genie from Aladdin. You've never had a friend like me. Right. So I am we're going to help you become, sort of know what you need to do next. Right. And so, another way of expressing that is NBA, or next best action. So we're working on, and it's very difficult, creating that kind of next best action structure for the consumer side, so they know what to do next. And then for the clinical side, what we need to do is to risk score and say, here are the people that are likely to readmit, or you should intervene here. And so that you can only do that when you have massive amounts of data, or at least more comprehensive information about the procedural history, the transaction history, and so on, and real-time transactional data. And so just with everything we've had to build as a very small, 12, 15 person company, it's very hard to do all of these things. But so our job is to focus on that sort of those core nuggets, in order to just be able to do those things well.
Yeah. And I really feel that the near invisibility on the professional side, and the not just ease of use, but the sort of the seamlessness and the familiarity that you need on the so-called consumer side, right? The family side, right? That friendliness, that easy, oh yeah, I know exactly what has to happen here. Oh, look, this is magically guiding me. I should call, it's been 6 months. I need to call and make an appointment, or something, right? Like to just, as I was saying, my personal experience is that, man, that it's a complicated system to navigate, right? So if something can help me through that, that is truly a magical experience. So just a couple of questions more. One is, it's like, what's next, right? So you've been sort of battling through a bunch of things. You've got this idea about how to have what kind of user experience you need for the different parts of the app, I suppose. What's on your horizon? Like, where are you looking to? If I'm a UX designer and I'm thinking, I want to use this COVID time to upgrade my chops in, what kind of things should I be looking to, so that when I talk to a guy like you in 3 months' time, and you're going, yeah, we're really thinking about X, and I'll be like, yeah, I did that.
A couple of things. One is, we have a lot on our plate already, because we have a lot of projects and a lot of and so on. So we think of ourselves very much as part of a digital health ecosystem or value chain. And so through the digital supercluster, we have, and other innovation initiatives, we have 7 funded projects, which is really hard for a company our size to take on. We've had to start using external development teams, and we're recruiting and so on. So, there are things that are providing more specific use cases, but then it's really what I was just speaking to in terms of that sort of vision of this sort of, the 2 different kinds of systems doing, much more integration. So we handle a lot more data quickly, or use a lot more data to drive the experience, and changing the UX to sort of create that sort of simple, yes, of course I should be doing that next, or, creating an experience where somebody wants to get up and exercise, wants to change their diet, wants to help their family member, and lean in and say, hey, I can take you to that appointment, or hey,
Mm-hmm.
let me take you for a walk, or make your meal, and so on. So that's, we have a North Star that is really well understood by everybody on our team. It's just really, really hard to get there. And so having a new CTO and a new head of product that we know and trust, both of which they were both advisors and
Mm-hmm.
consultants too, so they're known quantities to us, but they have very dynamic mindsets, and so they are working on the next version of this, and the rest of us are kind of serving, we're advisors to them, but the rest of the executive team and kind of work for them in a way, in terms of enacting this vision. So it's hard to step back when you're a founder and say, okay, there are better people to do this, but there are better people to do this than me.
Well, that's a good sign, actually, that you're getting to that point where you're saying, yeah, let's, hey, you take that bucket of stuff. I've got this other pile of stuff to deal with. So if I'm trying to make an informed choice, just a little, maybe look under the covers, if I want to get into these kind of complicated apps, and I'm a UX practitioner and I've got some good skills, and I'm trying to make a choice whether I should be looking at things like voice and natural user interfaces, AR, XR, MR, mixed reality, or augmented reality, or maybe AI. Which of those three things do you feel like are big things maybe coming for you that, I feel like if they're happening in your world, they're happening in other worlds, right? And one of those things is going to be bigger than the others.
Yeah, I mean, okay, that's a great question. I mean, AI is happening in an enormous way in healthcare. So if you look at the cluster projects and so on, there are things that are happening that are, when you look at radiology, I mean, a machine can just read images more effectively, quicker, more consistently than a practitioner in many cases for certain kinds of conditions. So we have a number of projects that involve AI. So we have partner firms that are good at marking up the images and results. They send triggers back to us and say, trigger this care plan because here's the diagnosis, and then a workflow happens through Careteam. So I mean, AI is the real thing in healthcare. It will do much more, and it will, for us, it isn't what we want it to be yet in terms of being predictive. Our workflows are much more algorithmic, but it will become as we get more and more data. So some of our early use cases were with dementia, in dementia. And the problem with dementia is that there's just not a lot of interaction, a lot of transaction data. And so, it's, whereas something like heart failure, there's a lot of, automatic and transactional data, a lot of check-ins, a lot of meds information, and so on. So, I mean, AI, we have a number of projects where AI is involved. So we think that voice is going to be a big thing. And so that's, we're starting to get the point where voice is going to be something that will be HIPAA compliant. So obviously we live under pretty strict healthcare regulation. So HIPAA, PIPEDA, GDPR compliance is critical to that. And so, voice is coming on, and we think that there will be certainly things, even if it doesn't interact with personal health information, it's certainly going to be part of the user experience for us. I think that will come sooner. VR, mixed, MR, those kinds of things. I mean, there are some very specific applications. We've spoken to a lot of researchers and a lot of innovators who want to do things with mental health, with virtual reality and avatars and bots and those kinds of things. We're trying to be way simpler and much more mainstream than that. So we think voice and obviously AI are going to be mainstream, but
the biggest things.
We're not interested in the other. We're in sort of the VR kind of world. I mean, there are great things happening for things like surgery training in virtual reality. They're incredible,
but not so much in the space that you're in. I get it.
Care coordination and patient engagement, that's not a thing.
All right, we're almost at, wow, 7:45. One last question for you, Rob, and then I'll just open it up to the floor. You have clearly learned so much along this journey. Thinking about the user experience from a practitioner point of view, thinking about it from the end user point of view. Do you have like a piece of wisdom you can share for UX designers, product managers, business owners? If they're struggling to implement their own digital strategies, if they are trying to work their way through this, do you have one little last nugget, hey, this is one thing I learned, to carry that one forward?
Yeah, other than don't get into digital health, because it will ruin your life and make you broke. No, no.
But yeah.
I mean, that's a great question. I mean, I think the biggest thing is that, we build things and expect them to work, because we're so used to digital experiences and digital lives and so on. And, certainly in what we're doing, I mean, what we've learned is that, and we thought we knew this too, coming in, but users will not do what you expect them to do. And so anything you can do to avoid building anything to gain the insights or get a little further along, is what I would do. And the other thing is that people in healthcare want to be helpful, and they want to tell you what things are, and they love the vision. So we've sold them on a vision, we got them excited and so on. But it's like, for some of these people, they kill us with kindness and encouragement, rather than telling us like, this will never happen because, we say we do team-based care, but in reality we don't. It's really just it's just lip service. And so the thing is that until you actually get in the trenches and see what people will do with it, and what they're motivated and paid to do, and what they are able to understand, it just won't happen. And so, I would, go back to the ask why 5 times, the old Toyota way kind of questioning. It's just like, it is just insane how this should work for you, and it should work, it should happen this way, but it just doesn't. And so, hard lessons, and we're unfortunately we're going to learn a lot more of those hard lessons as we keep going. I wish I could say that I've reached some sort of an end point or point of wisdom, but it's really just constant journey in terms of doing that and reminding ourselves, like, we cannot build until somebody has actually, like, it's so crystal clear. It comes back to that, sorry, just one more point on this. It comes back to that thing about things that work in healthcare are so simple and so easy for everybody that's involved to agree on, because what we're doing, it's not so much about what we do, but it's the impact that we have on the environment in which people work in. And so it has to be so simple, not just for the physician or the nurse or the healthcare administrator and so on, but it's for the entire workflow. Because we're not the point. We're a supporter of what's happening in the hospital, what they do. So anyway, so that's, I think I gave you like 4 points instead of 1, but users won't do what you think, ever.
Ever. That sounds, I mean, it's like, to me, I hear research, more research, and then again, but wait, do a little more research.
Yeah, prototype.
Right? Prototype, test, prototype, do some more testing, do some more research.
And for environmental healthcare, it's do things in, we're way too complex. And so we're peeling back to simpler. So we can do the complex stuff behind the scenes, but for every user, it just has to be like the easy button. It's ridiculous.
Yeah, I hear that. So it's wow, it's already almost 10 to 8. Does anybody have any questions? Do you want to drop them in the chat? And then this is your chance. This is, Rob's been there, done that, has the scars to show for it.
Yeah, been there doing that.
We had one question that came through the chat so far, and it was from Gates from Toronto. And can a role person, for example, a nurse, both share info like a patient's next appointment as well, or also monitoring? So being able to monitor, say, patient blood pressure remotely, just to add more like interactive role in the patient care between the different practitioners?
Okay, so there are a couple different questions. I don't fully understand the question, but there's an increasing number of devices and so on that will be added in. We don't have that functionality just yet because we don't have the use case for it, but we have partners that have devices that do that kind of remote sensing, and that automatically bring it into our platform. So we're essentially trying to be an integration play where these kinds of devices and use cases will be able to connect to us and through published APIs. In terms of sharing information, there are we're governed by very, very strict regulation, and so within a health system there's implied consent, and so they can share with people that are involved in the care of the patient, but only during the time that they're involved with it. And so everything that we do is based on patient consent, and then obviously we have to, anytime the patient enables anybody to, or the patient has to enable others to see it, or a legal advocate has to be involved in order to see the information. So I'm not sure if that was quite the question, but it's everything needs a workflow that's clear. And then we also have to enable them to revoke consent and access.
Mm-hmm.
There's a lot to build. It's just a big pain. It's a pain obeying the law.
All right, I'm not seeing any other questions in the chat right now, but I have some questions. So I was curious.
Go for it, Dave.
So how do you see, sort of zooming into sort of the service experience, who is driving entry into Careteam? Is it the patient who knows about it, who's able to involve their like the different medical professionals that they work with, or do you see it actually being led from the professionals involving the patient, saying, "Hey, this is one thing that you could integrate in"?
Yeah. So I mean, the people that are really driving it at this stage are really early innovators and champions that have a problem. And there's some certain groups that have very difficult problems in terms of care coordination. So highly complex patients. So for example, highly complex sick kids and so on just have a need from, where they're, they just have dozens of people involved in their care. And so things like encounter notes and coordination is really needed. So those kinds of really intense use cases are the ones that are working first. And then areas where there's transformation, like the Ontario Health Teams. So executives, at the top of organizations are getting involved in driving the process of doing this. And in some cases, health authorities and so on are, they're looking at it, but it's not driven by the patient at this stage. We've decided to be sort of our strategy is B2B to C. And so once we essentially are a more usable, more useful, better application, then we can start to integrate with, or we can start to approach or sort of enable the consumer more effectively, but we're not there yet. So.
Gotcha. Okay. I'm not seeing any other questions, so I have another question. I was curious about how the information actually gets into Careteam. You had mentioned previously the challenge of integrations being one of the big design challenges as part of this project. So I was just curious if you could share with us your strategy, because there's lots of different entry points for this very different information, from, say, your massage therapist who's working for someone who's in a car accident, or occupational therapist, and all these different organizations.
Yeah, for sure. So, I mean, there are all kinds of different ways. So we integrate with the electronic health record for the hospital. So we get access to certain information. So patient demographics, or medical number, and certain documents or messages are sent to us. We configure the application for the care plan content. So we develop templates and playbooks and so on that are provided by each department or each clinician to sort of deploy a care plan, either and that usually has to be deployed by a person. Then somebody can actually manually type in care plan information and so on. And then obviously devices can automatically come in, and partner firms that do other things and connections to other databases like, you know, Panorama, which is there's a new initiative called the BC Health Gateway, which will provide meds information, let us pull it in, ask the patient for consent to use their data, and so on. So it's really an integration play, because there's so many different pieces that are happening. And then obviously the patient can do a check-in and say, you know, we can ask them for a pain score, and ask them how they're feeling and so on. Or we can send them an inventory to, you know, their standard inventories around depression or anxiety and so on that we can, or mood scores and so on that we can do or use. So, you know, it's really the multi modes of information getting into the platform. So the key is to sort of make that into something usable from a decision support or a trigger perspective. So, you know, healthcare is awash in data. So how do you translate that into a meaningful trigger, either for the patient, the patient's family, and or for the healthcare side? And then, of course, the clinicians and so on, we integrate with their EMR, so electronic medical record or health record, so that they can, and that's something that we're continually working on, just to have them interact that way. So they, you know, they're not going to respond by text. So as I said, information goes back into the EMR.
Cool. Yeah, that's a big problem to solve for you guys. That's a massive, that's one of the giant boulders in the way, right? To figure out how to get information into the system from all these different places. Yeah. Dave, you have any more up your sleeve? It's pretty quiet over there in the chat.
Looks like Gates from Toronto has his hand up here.
Hi.
Hey.
Yeah, I worked on Panorama in the past when I was in Vancouver. It's a huge project. But one of the things that I picked up on in terms of you know, what you've been giving us as an overview about Careteam is you know, really trying to engage the patient, you know, your user. And I guess one of the key things is trying to always identify actions and goals, and maybe some of that data, databases, for example, that you look at for information, identifies in terms of different care plans, you know, risks for certain cases, and therefore helping to drive, you know, some of the decisions that need to be done towards a care for a certain category of patients, and therefore some goals and actions for them, right? And it's in that context that Dave kind of mentioned my question earlier, is for some patients, for example, maybe someone that's helping in the care of a patient, maybe monitoring their blood pressure is important because they have high blood pressure, for example, right? Mm-hmm. And so then you get into situations where maybe a parent or the patient themselves or a nurse could just request that they monitor their pressure, request that they do certain things or perform certain activities, things that help towards that goal of reducing their blood pressure. I know, for example, there's a company in the US called Viamed, and they basically just deal with respiratory problems and trying to keep patients out of the hospital.
Yep.
And it's spelled VIEMED. Yep. And what they do is, you know, over the years, they had nurses go to patients' home, show them how to use equipment, go on a regular basis to monitor. At some point, they basically engage remotely the patients to try to take certain actions and to even train them how to use certain equipment or how to take certain actions. it
Mhm.
sounds like that you know that your products and your strategy can really benefit, and you're probably already doing this. I'm kind of speaking somewhat out of ignorance of your company, but I think trying to identify for the different care plans, kind of the goals and the actions that your target audience really needs to focus on, and trying to progress them towards that and help them achieve those, I think will really help the engagement of them using the tools.
Yeah, no, I mean, I think, you raise a couple of things. I mean, one thing I'll mention with, one big trend that you see in digital health is that blended HR, or sort of manpower or human power, and technology, where people are providing both technology and the resources, the people to manage certain patients. And so a lot of digital health companies will get contracts where they do both sides of that, because they can actually, they can use their own technology to manage a group of patients more effectively. And so, that's a strategy that's open to us. And so we may do that. I think that there's but I mean, what you're speaking to is that, it was really sort of a key in terms of, maybe I didn't answer it well enough with Karen's question about where we're going, but we have to drive and be useful to the sort of economic model of our clients. Otherwise they just don't care.
Yeah.
We're not helpful to them if we don't do that. So we're, one trend that's going on in the US, of course, and to some extent in Canada and elsewhere, is value-based care, where the hospitals and providers who used to do fee-for-service and get paid, and that's most of healthcare, by the way, still 85–90% of healthcare in the US is fee-for-service. So they don't want to keep people out of the hospital. They don't want fewer procedures. They want more of them, because that's how they make money. But there's the models are changing, which is a big key trend for Careteam, which is we're starting to get capitated or larger payments for a hospital to be responsible for a patient for longer. And so now they start to care about what happens outside the hospital. And so, just what you're saying, Gates, it's just sort of, that's where we have to work, where it really, that the care pathway that's needed and the goals that are needed by the client, have to be, baked into everything we do and delivered to that client. Otherwise we're not going to be successful.
Thank you so much, Rob. We're at the top of the hour, and I just want to thank everybody for joining us tonight. I'm going to hand it over to Dave and Curtis to say goodnight. And thank you from Vanuatu. Thank you, Rob, for taking the time and just being so open and sharing what you've been thinking and what's been happening.
Thanks for having me.
Awesome. Yeah. Thank you very, very much. I know I definitely learned a lot, and thank you very much to the both of you for an awesome fireside chat.
Yeah. Thank you. Thank you for hosting.
Awesome. All right.
Thank you.
Good night, everybody.
We will be providing a link to this recording if you wanted to have a look at it later. I believe Karen will arrange that, and I'll be posting through the channel. So yeah, thanks again.
Gorgeous. All right. Thanks.
Thank you.
Good night, everybody.
Take care,
Thanks, everyone.
Bye.
Bye.